My name is Michael DeFee. I'm a restorative dentist and an educator at the Mod Institute in Charleston, South Carolina. And I want to talk to you today about 4D jaw motion and how that's enabling us to have a truly functional digital twin. So what we've been striving for a long time is to have a truly digital twin where all our planning can occur digitally, where we don't need any analog process to be a part of any type of restorative treatment. And with the recording of 4D jaw motion, we're now truly at the stage where this is a possibility. The other side of the coin with 4D jaw motion is it provides insight into diagnostic processes that are very difficult to garner without. And so for this patient, when you look at her open and closing, you can see a deviation that would potentially be very difficult to pick up if you're just using a typical analog workflow as part of your diagnostic. And so what that can do is it can provide us a little bit of insights that help us to have discussions with our patients on the front end about dysfunctions that we're seeing within their temporomandibular joint that can help us in how we plan our treatment. And so what that allows us to do is to get results like this, where not only are we planning the aesthetics perfectly, but the execution of the treatment is in complete harmony with the patient. So that what we're ending up with is a treatment process that is both efficient for us and very comfortable and exciting, shall I say, for the patient, where our treatments are just absolutely knocked out of the park as far as being in complete harmony with their function. And so one of the things that we know is a major adaptation risk for any type of dental treatment is temporomandibular joint disorder. And so when you look at the literature, at a couple of systematic review and meta-analyses, what you'll find is this is maybe quite a bit more common than what we typically would have thought. Around 31% of patients have some level of temporomandibular joint dysfunction, especially when you include patients who are asymptomatic. That can be very difficult to assess if you don't have a super comprehensive process in place in your office. My question to you is, are you finding that that's the prevalence you're seeing within your patient population? A third of the patients with some level of joint dysfunction? And so if you're delivering comprehensive treatment and you're not assessing this level of prevalence within your practice, you're putting yourself at risk for introducing treatments that could cause, some downstream consequences for your patients, both from a patient satisfaction standpoint, but also from a patient confidence in you and your ability to finish treatments efficiently. And so there's a few ways for us really to look at a comprehensive process for assessing temporomandibular joint dysfunction. One of them is symptomatic questionnaires, but we know that sometimes patients aren't the best historians. Maybe the symptoms were a long time ago and they've adapted and they've forgotten. Maybe it was below the level of what they would really consider needs to be reported to you as a provider. There's certainly things that can be missed with these symptomatic questionnaires. We can look at exam forms that are validated by the literature, like the DCTMD, where we're looking at lots of things that, aren't necessarily related to patient symptoms, but are related to function, like jaw movement, range of motion, sounds. These are certainly things that can provide us clues in assessing the health of the temporomandibular joint. The other is a more classical way, load testing. It can certainly provide insights into the health of the masticatory system. Radiographically, we can look and see, are our condyles in the correct position? Do we have any remodeling within the joint? Does the condylar head look normal? The gold standard for assessing the health of the TMJ, especially when we talk about discal status, is still the MRI. But when we look at some newer literature that's building on, some more classical insights, we're finding that there's a high correlation to joint movement, especially when you look at open and closing, and discal status. And so in this paper, what they did was they used computer vision, which is a type of AI, where they're looking to see if they can diagnose based on the open and closing what the disc status is for that patient. And so what they found was there's a high correlation with sideways skewed opening and closing and disc dysfunction, whether that's with reduction or without reduction. So we're starting to build correlations where we can assess things in a more reachable way for our patients, because we all know that MRIs are both expensive and sometimes getting appointments can be really dragged out. And so it can certainly be out of the reach of some of our patients, but we still need a comprehensive way to understand the health of the joint before we start delivering any type of treatment for patients who may need to be stepped through the process a little bit differently than patients who don't have any type of joint dysfunction. And so sometimes it's very obvious, like in this patient. When you look at that skewed opening, if you're assessing movement, you're certainly going to be able to see that visually. It's very obvious that that movement is sideways skewed. But sometimes it's not, like in this patient. If you're looking at this just visually, it's going to be very difficult to see this slight bit of skew and this kind of jump over on the closing stroke. But when you look at it graphically, it becomes very obvious. And so these are truly valuable information for us in assessing the health of our patient's temporomandibular joint. And so we know this is critical because patients who have had a history of TMD symptoms or just any level of joint dysfunction are certainly at adaptive risk for any type of dental treatment that we are going to undergo. And so when you look at this systematic review, what they noted is patients with TMDs are hypervigilant to stressors and thus may adapt less easily than patients without TMD history. And so what does that mean for us? It doesn't mean that we can't provide treatment to patients who have a history of TMD, but it means we need to think about that and approach it differently. Maybe we need to phase things over a longer time so that it's much easier for them to adapt. We certainly need to have conversations on the front end where we're discussing the potential of maladaptation and the potential that we may need to take the treatment a lot slower than we would for patients who have completely healthy joints. The other value in having recorded jaw motion is we can now start to assess the coordination and the reproducibility of functional movements within our patients, like chewing strokes. And so what we know is having coordinated musculature and masticatory efficiency is critically important for us to be able to maintain our cognitive abilities as we age. And so what we see is when we look at this study that there is a correlation between the loss of masticatory efficiency and cognitive decline as we age, whether that's related to tooth loss or whether it's related to sensorimotory control, where we're just not really able to chew in an efficient and functional manner. And what we know is when patients start to lose this ability, they start to avoid foods that are really critical for proper nutrition, fruits and vegetables, meats. And so we need to be assessing this within our patients and both helping to regain that for patients who've lost it, but helping to maintain it for patients who are still able to chew efficiently. And so borrowing from the famous management consultant, Peter Drucker, what we know is you can't manage what you can't measure. So the question I have for you is, are you measuring masticatory efficiency within your practice? There's several ways to do it. Questionnaires, mixing tests, or recording the motion and looking at how efficient and coordinated it is. There's classical literature that tells us that certain chewing patterns tend to be more effective than others. But if we don't have standards for how we're assessing this, we're not going to be able to rehabilitate it, and we're not going to really be able to help our patients maintain their function in a way that they need to stay healthy for the long term. Like for this patient, her complaint was, I just feel like I don't know how to bite anymore, and I really want to be able to chew a steak again. When you look at her function, it's completely uncoordinated. She's all over the place when she's trying to chew. Be very hard to see this if you're just assessing this visually and not actually recording it so that you can go back and re-look at it as you're treatment planning. The other thing that we know, whether we're planning cases digitally with an articulator or analog with an articulator, is that the border movements that we are designing with on the articulator, they don't really truly reproduce the function that we're actually seeing within our patients. And so even when we look at the accuracy for the border movements that articulators are designed to reproduce, we find that they're only about 73% effective in reproducing those movements themselves. So there's certainly inaccuracies within just planning off of an articulator that will have to be worked out in the temporary stage, which is going to decrease the efficiency of your treatment itself. The other thing to think about if you're planning cases analog with an articulator is that when looking at a recent study that tried to see what level of interchangeability and accuracy there are with certain articulator systems, none of the systems that they assessed over the 1-year period maintained interchangeability for any acceptable level of accuracy. Even when they expanded what they called the level of acceptable inaccuracy to 160 microns, none of the articular systems were able to reproduce that. And so 160 microns of inaccuracy is definitely not a level of inaccuracy that I would be comfortable with clinically. If you have a crown margin open more than 160 microns, the literature certainly tells you that that's not acceptable. And so for me, now having the ability to record these movements, I'm able to move to a world past articulators and use function for planning my restorative treatments. And so the system that I like is the Module system, both because the UI is easy to use, but also because I can take those movements into my digital design software, which I prefer Exocad, and I can plan using that digitally. And so the question is, are these systems really accurate? And so when looking at a recent study, we find that the level of accuracy is very striking. This particular study found that for trueness, the Module system was accurate down to 11 microns. So more than 10 times more accurate than analog articulator systems over that year time frame. And what we know is the digital systems don't really get out of calibration, at least for the design software, like analog systems can. The other area where we're able to both assess and plan is with our opening and closing strokes, which we know are very hard to replicate using either digital or analog articulators. And so for this patient, what we see is he had some anterior restorations completed and they were not in harmony with his closing stroke. You can see that he's sliding back into those MIP contacts, and that's causing some unnecessary wear on those mandibular anterior teeth. And so being able to plan with that in complete harmony allows us to move past needing to assess and adjust that within our temporary stage. The other thing that we can record and plan for is true masticatory function, where we're recording these chewing strokes. We're going to take them straight into our digital design software, and then we're able to harmonize the position and the size and shape of those posterior cusps so that for patients who don't need any type of chewing function rehabilitation, we can have our restorations completely in harmony with their learned chewing motions so that the level of adaptation needed is very, very minimal. But the question that we all probably have at this point is, why do we care? You've probably been doing restorations for a long period of time, analog with articulators, or maybe you're not using an articulator at all, and you've done well. What we know is with the literature, if we're not planning with these functional movements in mind, is we're putting ourselves at risk for introducing pathology into our patients. And so what this study found was for molars and other posterior teeth that are not in harmony with chewing strokes, we're at risk of causing pathology such as tooth mobility that we really don't want to be doing. What their conclusion was, occlusal evaluation with border and tapping movements might be insufficient, and functional occlusal evaluation during chewing movements can be clinically useful, both from assessment and from a planning standpoint. And so now, with a completely digital comprehensive records process, we can both plan and execute any case to a level that just has not been possible in the past, both from an aesthetic standpoint, but also from a functional harmony standpoint. Whether you're new to these digital processes in your office or you're just starting to integrate more advanced tools, you're going to improve both the level of predictability for your treatment, and you're also going to lower the stress for both you and your patient. And so I'm Dr. Michael DeFee from the Mod Institute, and I'm so excited for you as you continue on this digital journey.